for everyone, especially for the poor and the vulnerable. Right now, the government of the minister, we're talking about 17,000 PHCs. We have the Basic Healthcare Provision Fund, who is talking about increasing the facilities to 17, primary healthcare facilities to 17,000. 17,000 is a drop in the ocean to cater for the poor and the vulnerable. So we have that. We have many other challenges as well. Education. How many people at that level understand some of the services that primary healthcare, what they offer? How many? You know, I was just thinking about one of my communities and I'm asking myself, what will make a mother who knows that, if she knows that vaccines would help the life of her child and somehow does not take that child to the facility? That question keeps ringing in my mind. Mothers are known to love their children. We love our children desperately. Then again, you still have people not accessing those primary health care centers and accessing the facilities. Simple. They don't know. They don't know. Lack of education. Nobody has educated them on the value. And vaccines is something that has to do with trust. You are taking medicine for a disease you have not yet had. You know, that is what vaccines are. So what the lack of trust at that level, the lack of knowledge at that level, the primary healthcare centers themselves cannot cater to, you know, the citizens. They don't have what it takes. All these things put together makes it very difficult. And there's something that I like, a phrase that I really like. It says, pot to arms. That was one phrase that was used throughout last year. As long as, for instance, I'm giving vaccine as an example, vaccines have not touched the arms of the child or whoever it is that need those vaccines, it's a failed project. So these are all just some of the few basic things that I just want to mention concerning why people do not access primary healthcare services, because many times the services are not even there. Thank you.
Thank you so much. And I think that's a very, very good point to make. It's a great perspective that I think sometimes we fail to recognize the importance of promotion activities, the importance of education and awareness, so that people even know that these primary healthcare, systems, infrastructure exists. But speaking of infrastructure, I want to pick the brain of Dr. Olumide a little bit. From a global and regional perspective, what do you think are some of the systemic and financial barriers that contribute to low access to primary healthcare services in Africa and in Nigeria?
Thank you, Shelley. Perhaps that shouldn't be rocket science now. So as it stands, Nigeria is a particularly large country, wealthy, but considering the size and wealth of the country, the level of spend on health is abysmally low. In fact, at this point in time, you could say that Nigeria is one of the lowest spenders on health in the entire universe. It is that bad. At 0.5% of GDP, it simply means that we're not prioritizing the health of our citizens. So there's a basic assumption that we need to first understand. Chika, you highlighted a number of things, and we need to make the connection in a tangible manner. You mentioned the poor and vulnerable, the people who are living in geographically hard to reach places, in rural areas. For those populations, and they constitute a lot, for those populations to enjoy the kind of health outcomes that we're talking about, they need public financing. The alternative is for them to spend out of pocket. They cannot afford the care that they need out of pocket. To cover out of pocket, it then means that government must spend its own money. So going back to my statement, public financing is essential, is mandatory for allowing those populations to enjoy care. And when that financing is so low, then we should probably not be surprised about where we are today. But perhaps just a ride on that very quickly is to say, okay, if this is your reality, you're not spending enough. Okay, the little that you have, how are you spending it? Within that bucket, how are you prioritizing it? I hate to say this, but then if you can all picture an inverted pyramid, you're not spending enough. The little you have, you're then spending on tertiary care, for example, which further means that those who are deprioritized in the first instance get hit the second time. So you're spending the bulk of your monies on tertiary care, which is accessible to less than 5 to 10% of your population. So it means that the people that need it the most are not getting it. So probably to end with just some, in brief, we really do need to spend more, but we cannot spend our way to good health outcomes. Whatever we spend, we also need to prioritize to address the needs of those who require it the most. So let's prioritize on where the bulk of the disease burden is, which is around reproductive health, maternal, newborn, child, and adolescent health. And let's prioritize at the level where it will make the most impact, which is at the level of primary healthcare services.
Thank you so much. Thank you so much, Dr. Olumide. And Dr. Olumide and I, we've had a lot of experience in, advocating. We've worked together in the past, advocating for increased government expenditure on health. And I'm going to come back to that. But I think it's important that we just tailor the conversation a little bit further. And I'm going to ask you, Kafayat, what financing models do you think can be adopted to ensure sustainable primary healthcare delivery in Nigeria's rural areas? So emphasis on rural, because like Olumide said, it's important that we are, just tailoring all of our interventions to ensure that the people that don't have access to these services now have access to these services. So I would just like your perspective on that.
Hello, okay, it's working now. Okay, good morning, everyone. Thanks, Shirley, for the question. So I'll be riding on what Dr. Olumide has already said. He has already laid the foundation for this. So in health financing, when we talk of health financing, there are two things that need to be considered. The two things are very important. The first one is ensuring that there is more money for health, for the health sector, just like Dr. Olumide has said earlier. And another thing is for that money to be used to generate more health. So in essence, for us to get results for the money being spent. So to make more money for health, to ensure that there is more money to be spent on health, there are several ways of doing it. And everything boils down to pulling funds from different sources. From the government, most importantly, because it's only government fund that you can really rely on. It's the most sustainable way of financing health. From the government, from donors, from private sector, informal sector organizations, private individual philanthropists, and the rest of them. And when we are doing all this, what is the most important is to ensure that this benefit is felt by both the poor and the rich. And specifically, we should ensure that it gets to the hard-to-reach areas, who are mainly, in most cases, they are the underserved people in our society. And sometimes, and in most cases, they are being bypassed. So how do we ensure that these funds actually get to them, the people in the underserved areas, the hard to reach areas? When we have programs, interventions, health financial interventions, like we have BHCPF, Equity Fund, what some donors are already doing now, the first thing is to thank God there is sector-wide approach now that is trying to put things in order, reducing fragmentation and all that. We can leverage swap to get more funding that can go around. Then to now ensure that these funds actually go around, we need data. We need a lot of data. We need to conduct what is called benefits incidence analysis on these programs that are being implemented. This benefit incidence analysis will ensure to help us to know the distribution of these funds, the distribution of the benefits of our interventions in terms of socio-economic characteristics, especially geographical location. We need to know whether the funds are actually getting to this hard to reach area. And again, in terms of gender, income level, are the poor people really getting it? Is it getting to women? Is it getting to men and all that? And when we have this data, we'll be able to make amends where necessary. And this, in all, this will ensure that the people in the hard to reach area are not forgotten. We'll make sure that we get them. Then, when we now, after ensuring that the funds get to the hard to reach area, they have money and all that, we also need to ensure that this money actually does what it is meant to do. We need to know that the services are actually being provided. And the first thing I think should be done is to make sure that there are people to provide services in these rural areas. If you spend all the money, you have the facilities, you buy the commodities, but we don't have people there to do the job. It is common knowledge that people don't want to work in rural areas. So part of what the money that needs to be spent is incentives for health workers to be willing, to be motivated to stay in these rural areas, increase their rural posting allowance and pay it to them regularly, give them accommodation, make them comfortable enough to stay. Then again, like Dr. Lumide said the other time, we are spending like 0.5% of our GDP on health. So it's not likely that we are going to have enough funds in the next few years. It's going to take some time before we get adequate funding. So how do we ensure that what is being spent right now is actually giving us what we need? We need to remove all sources of inefficiency as much as we can do. Let me just cite an example to buttress what I'm saying here. We did an assessment last year, on HRH landscape in 10 states in Nigeria. And one thing that was very common among the 10 states is absenteeism. Health workers absenteeism. You get to a facility, the facility has 30 people, 30 health workers on the payroll. Government is paying them every month, but only like 10 of them is on the like 10 of them are on the roster and even the attendance register. So imagine if all the 30 of them are providing service, they are there. It will make a lot of difference. Then monitoring and evaluation needs to improve, supportive supervision. When they know that people are coming to supervise them, they are going to work. They will be there. But government, sorry to say this, sometimes the government workers even don't want to go and conduct their supervision in these areas. They are neglected. So this has to be taken care of so that the money we are spending is seen. So I hope I've answered your question.
You certainly have. So I'd like us to pivot a little bit to strategies for, collaboration, just really trying to understand the way forward to advance primary healthcare systems in Africa. I have a question for you, Chika. So you talked about, lack of proper awareness and education. I'd want you to dive a little bit on some successful advocacy initiatives that has been able to do that. So just drawing insights from case studies and the effectiveness of advocacy. But also, I also want to get a sense of how you think essential health services like maternal and childcare, how you think these services can be deployed and how we can leverage technology as a solution, to improve, access to healthcare. Yes.
Those are two questions. Anyway, Nigeria has done a lot of work. This is about Africa, and the problem of Africa is basically the same. Nigeria, we have the Basic Healthcare Provision Fund that's supposed to take care of primary health care. And this present government, with their swap strategy, is also looking at that. And then you have Addis Declaration, you have Abuja Declaration, you have recently Abidjan Declaration. So we have all the policies, all the declarations, everything that is necessary to make sure that primary healthcare is actually primary healthcare. Now, what's the next implementation? Implementation to make sure that these things work as they are supposed to work. That's where the problem is. The first thing I want to say today is collaboration. Collaboration is very important. The government cannot do it alone, whether we like it or not. The government cannot do it alone. I'm talking from a CSO point of view. I'm a CSO. So because of that, all hands must be on deck. CSOs are the nearest to the community. They're the ones that hear the voice of the people. Apart from the government, you have the government, you have private sector, you have CSO. Everybody, all hands must be on deck to make sure that health gets to all that need them, especially the poor and the vulnerable. Let's not forget the citizens. How do you get the citizens to know? They themselves have to put their heart in the ring. I went to one of my communities recently. There's a PhD next, about a minute walk. A child is very sick. I'll give this example. It's a true story. The child is very sick. Then they call me. It's one of my adopted communities. I said, okay, go to the primary health care center. They took the child to the health center. The nurse told me that it was late, that we had to refer them to Maitama General Hospital. Why? Because the mother stayed at home for too long, patronized the chemist, wrong chemist, and then the case had become terrible. We had to rush that child to Maitama. Maitama said it was that they couldn't do it, that we have to refer the child to National Hospital. But before, because the child could not breathe, but before they did that, they were going to do some form of nasal engagement. So they did it. Immediately they put whatever syringe inside the baby's nose. The baby died instantly. Instantly. What happened? The baby died because the first time they had this problem, there was a primary health care center near them. They didn't access it. They didn't know the services that the primary health care center was going to give to them. They didn't understand it. They didn't have that education. By the time they called me. I said, go to the primary health care center. It was late. We lost a child. And that is because of lack of awareness, lack of education at the primary healthcare level, which is why I'm saying today we're talking of swap. We're talking of, now there's a new one. They just said CS, cesarean section now at the primary healthcare level will be free. How many people in the community know? What you don't know, you don't know. I believe in two things: collaboration and education. These two things are very key to the things that we do. And we can leverage technology. Everybody has a phone. Even in those most vulnerable communities, they have phone. They can access SMS. So information can be passed through those channels very quickly in ways that can be understanding. Look, the way we have been doing it in Africa as a whole, and Nigeria particularly, has not moved the needle very far. We need to look for something more innovative. We need to make sure that the citizens of the communities are more educated and they are also involved in all the things that are happening concerning their health. The only way to build agency is knowledge. If you don't know, then you cannot build agency. So we have SMS at that level. Many people are on WhatsApp. I was so shocked in one of my communities. They were on WhatsApp. I was shocked. So they can leverage technology, give information, where to go, with the location of the health center. At least the community are the ones that should hold the government accountable. They should be able to go to the facility and be able to say, okay, I know that this facility is supposed to have A, B, C, D, and they don't have it. They should have that knowledge so that they can start to ask questions. In some of the communities where we have women groups as accountability partners. We have the Umuadas. They are the ones. What did they do? They got a small grant. From their grant, they bought a BP machine and put in the facility. You can imagine women in the rural areas buying BP machine to put in the facility. Of course, they will monitor their BP machine. They go every month to go and monitor the BP machine. Only last month, they told me that that BP machine is spoiled, and they will not agree because they're 500 naira that they contributed entered into that. So citizens engagement, citizens must be part of it to hold the government accountable. There's so much money that is going to go from place to place based on swap, based on BHCPF, based on many, many things. The citizens have to be included intentionally, and there must be collaboration of all sectors. Thank you.
Thank you so much. Thank you so much. So you talked a lot about driving government accountability and transparency. And I think that the media is a very good medium for advancing all of these narratives. As you were speaking, you mentioned two stories about the baby that unfortunately passed away, and then this really empowering story about women that are, using just a BP machine to ensure that people are getting their regular health checks and health screenings. And I think that these narratives are very important, and it's important that we understand the depth and the scale of the issue. And that's where the media comes into play. So we have Mr. Bissy from Premium Times. And I just want to get your understanding and your perspective and some insights about how can we ensure that there is more effective, efficient, and also, I think, driving narratives in reporting, health reporting narratives that are factual as well. How can we increase the level of health reporting in Nigeria to advance, all of the advocacy demands for driving and increasing PHC systems in Nigeria, and even just improving government accountability and government spending on our healthcare systems?
Yeah, hello? Hello? Okay. Yeah, the issues are very clear, and the role of the media is to just continue to highlight these issues. The challenges, the efforts being made to address these challenges through government programs, through projects, and other efforts, and the impact that these are having. As has been stated copiously here, the challenges are very clear. At least I think the most, the biggest of them is funding. Dr. here said that Nigeria is perhaps the country that spends the least on its health sector. And even after Nigeria hosted the Abuja meeting where the Abuja declaration was made recommending that 15% of the budget should be committed to health. It has never been implemented by any federal administration since then in Nigeria. It has not even been implemented by governments at the subnational levels. So, and other problems even exist that compounded that problem, because even if some governments announce a budget and then commits or allocates 10 or 7% to health, they do not always release all the funds. And when they do release them, then you discover too that the priorities are really not what the people need. So in the media, what we have been trying to do, especially at Premium Times, is just to focus on these areas, tracking government projects, tracking programs, calling attention to the needs of the people. The challenges are stuck. Everywhere you go, where there are primary health centers, we discover that they are ill-equipped. They do not have enough adequate staff. The staff are not, the workers are not committed, and the people have lost interest in many of these areas. And that is why a lot of people, they always pivot towards maybe alternative healthcare. And these are things that we always try to call attention to. So, the role for the media is to just continue to try to understand what the challenges are, the issues in this sector, and then continue to call attention to it and hold the government accountable. Because in many areas or in many cases, even when contracts for projects are awarded, they are poorly executed or not executed at all. And then, like she said, the communities, they are not aware. Sometimes many of them think they are being done a favor, not realizing that the money committed to these projects come from maybe their own taxes or the common resources. So people have to understand their rights and then track what is being done. And that is the area that I think the media can always help to do. Bring attention to what the government plans to do and ensure that these are really the needs of the people and that it is done. And if there are small gains, we always try to report them where they exist too, but we should never be tired of focusing attention on the challenges in the sector.
Never be tired of focusing on the challenges. I definitely agree with that. So, Dr. Lumide, I'm coming back to you. You mentioned earlier when you spoke about the inadequate focus from the government when it comes to healthcare financing. And I know that this is something that you're very, very passionate and particular about. Now, I want to hear your thoughts on how can healthcare financing in Nigeria be procured through various, alternative revenue streams. I mean, we've also had experience in advocating for pro-health taxes in Nigeria, for example, and we've asked the government to channel, the funding from these taxes into healthcare. Now, we understand the complexities and the complications with that, just with regards to how government allocates revenue. But from your own perspective, given all the wealth of experience and data and different case studies that you have working at the World Bank, what are some of the ways you think Nigeria should explore when it comes to healthcare financing in the country?
Well, thank you very much. So there's an area that most of us in the room will probably not necessarily pay attention to before, but now we have to. First pillar in health financing is, how does government raise its revenues? Most of us in the sector will probably not pay attention to that because we probably will spend a lot of time in terms of what was allocated to us. So you have people in the kitchen who are baking the cake. After baking the cake, they cut it up and then give it to sectors. That was probably how we used to engage before. We wait until the baked cake has been shared and brought to us at the dining table. But now, and part of your question is, what are the things that we need to do in the kitchen where the decisions are being made? Just to emphasize some of those. One is, yes, government wants to raise revenue because apart from the fact that we're not spending enough on health, the government's revenue raising capability is also one of the lowest in the world. So you could even argue that you can't spend what you don't have. And that's why you have this aggressive effort to shore up government revenues. And as I was saying, you might think that doesn't affect you, but it does. One is the area of pro-health taxes that you've mentioned. Right now, the lowest excise taxes on alcohol, on tobacco, on sugar-sweetened beverages are perhaps the lowest, again, in Nigeria, because this is a country that has relied a whole lot on oil rents, and we haven't paid attention to places where we could even raise revenue. And that's one area where I think everyone in this room, and in fact, we need journalists or people in the media to help with that campaign. And why is this important for us? We don't want people to buy these products because they damage health. And one way to do that is to increase the prices through increased taxation. But it even gets better, because when you raise the taxes, then government makes more money. And which is a second or an additional point to people in the room to say, well, if you raise taxes on these health bads, can you in fact allocate to the health sector? Across alcohol, tobacco, sugar-sweetened beverages, and we know countries that have done this. Please, probably we won't have time to go into the history of Philippines and how Philippines have been able to achieve universal health coverage, but the financing or additional revenues raised from these health bads were actually earmarked to the sector. And this is a key part of the Philippines story in terms of achieving universal health coverage. I've asked, initially I thought I was going to talk on nutrition, but that's fine. But you see, the second point with respect to health financing is, how do we advocate? A lot of our policymakers do not even know the consequences of not allocating enough money to the sector. People would rather build bridges, tar new roads, and that's what they're doing, rather than focus on the sector. Why do they need to do that? And, you know, Chika, you've given the story and everybody was like, oh, hey, that kind of thing. Very sad, you know, but people hear this every day and they move on. But you see, this is happening, not necessarily the deaths now. The deaths are the ones that you see physically, but there's something much more significant. And please help me show this slide. So the number or the percentage of Nigerian children who are stunted, in other words, who are suffering from the consequences of malnutrition because you are not allocating enough financing to health. One of the immediate outcome and the long-term consequences is stunting. This is an X-ray. I'm not sure, maybe there might be some doctors in the room who can read this MRI, but this MRI is telling a story, all right? The MRI on my left is the brain of a normal child on my left. Yeah. So.
That's on their right.
Okay, so that would be on your. You know what? Let me. Oh.
I'll point at it.
Okay, so two radiographs showing two brains, one of a normal child, the other of a stunted child. I will show you which is which. I'll stand up and show you. The challenge we have, and why I'm showing this, is the level of stunting amongst our children is increasing. Total number of children, 40% of our children becoming stunted. So we're not talking about the ones that are dying. We're talking about the ones that are going into adulthood. And everyone in this room will say, the future is about technology, it's about numeracy, it's about what you have in your brain. Now, the brain there is the brain of a stunted kid. As you can see, the neurons, that connection is not being made. That child will grow up into adulthood, but that child would pretty much be useless to the country. But there, we have 40% of our children stunted. So we seem to be dream walking into a crisis of catastrophic proportion. So sometimes when we say you need to give money to health, we need to spend that money in a much more quality manner, it has consequences. So when our leaders say Nigeria should be the giant of Africa, the giant of Africa is the one that will have a normal brain. You cannot have the giant of Africa if your children are growing into adulthood and their brains are not well formed. And the latest data, NDHS 2023, is saying that stunting amongst children is increasing. So the reason why I showed this is perhaps the concept of health financing might be abstract to people, but where we need your power is in the advocacy to show the kind of consequences that our country cannot be competitive, our country cannot take its rightful place in the Committee of Nations if you do not develop or if you do not invest in your human capital today. And the first step towards that is allocating adequate financial resources to the sector. Whether you have been able to mobilize resources or not, it's a priority for a country. Thanks.
All right, thank you so much, Dr. Olumide. That was a very nice technical session. So yes, I think that an example that I always like to highlight is South Africa. So South Africa implemented a pro-health policy that's called the Health Promotion Levy. And the Health Promotion Levy are levies that are placed on sugary drinks. And we're using sugary drinks as an example. But what I love about what they did with the revenue was that they allocated it to health promotion activities. And Ms. Chika here has talked a lot about, raising awareness, and the government also has a role to play in ensuring that citizens understand the harms of some of the lifestyle choices, to ensure that citizens understand the priorities, the infrastructure that the government is trying to put in place to ensure that we are healthy and we are thriving. But like Dr. Olumide said, advocacy is very, very important. Now, this is my last question before I open it up to just about 2 to 3 questions from the audience. So we've talked a lot about the barriers, we've talked a lot about the issues, and we've also explored various strategies for improving primary health care in Nigeria. But how can we here, as civil society organizations, as public organizations, private organizations, how can we foster collaboration that drives accountability? How can we foster collaboration that drives advocacy, that ensures that babies are not dying, that ensures that women can go into their primary healthcare facilities, have access to essential medicines, give birth safely, that ensures that our children are not, having or facing the potential of having stunted growth and not being able to contribute to the society and to the economy at large. So I think I'll start with you, Kafayat, and then we can hear from you, Ms. Chika, and then Dr. Bissy, and finally Dr. Olumide. Then we'll open it up for some questions. Yes.
Okay. Thanks for the question, Shelley. So, collaboration to improve healthcare is multifaceted, is multi-sectoral, multi-everything. So it's not limited to anyone. It starts, I'll start from the community. Let's start from the community, because now we are talking about how to reach, with our focus here is on how to reach areas. So at the community, a lot has to be done. The community members need to know that healthcare is very important for them. The community health system needs to be strengthened. And who are those that can strengthen this system? It is the community members themselves. So I'll give you an example of something that we did in our organization recently in Nasarawa State. So we went to Kefi. We bought health insurance for some people, I think about 440 people in Kefi. Then after buying it, we thought they would rush the card. They did not rush the enrollment card. We had to go from door to door to distribute the cards before they got. Then when they got it, they kept it somewhere. They still didn't use the facility, which means their problem was not really, the money was not the only problem they had. So we knew that we were strangers in that place. We could not persons. So we had the facility OICs, the World Development Chairman. Then we had representatives of different informal sector organizations in the community, including religious organizations. So we formed these community resource persons that we're working with. So they were the ones that were going from door to door, mobilizing people, sensitizing them on what the card should be used for. And with that, they were going to the facilities. Then on accountability, there was something we did again. Every month we had meetings with these community resource persons. The OICs of the facilities will be there, the WDC, and those other representatives. Then we would invite the Nasarawa State Health Insurance Agency and representatives of their state primary health care to the meeting. Then they would tell us what they are experiencing. So when you went to the facility, tell us what happened. Then they would tell them. At that same place, they would resolve the problem. Sometimes the problems were just very little. So that helped a lot. And they had the contacts of the people in MPHC, SPA, HCDA. So when there's any problem, they call them that your facility has started again. They did not give us this. They referred us. They did not answer us at the secondary facility. We even later involved their hospital management board in our meetings because of referrals, because they were having issues with referrals. So they started, and till today, we are no longer in the community, but they are still doing it. We still follow up with them, and they are still doing it because they are seeing the benefits of what they are doing. So the community first. Then again, we another set of people that I think we also need to collaborate with, that we sometimes don't reckon with a lot, is the private sector. In Nigeria, Ebola, not even only in Nigeria, in Africa as a whole, Ebola virus and COVID-19 has taught us, has shown us how powerful the private sector can be. We all saw what COVID did when COVID-19 happened. We saw how they quickly ran around, pulled some funds, and did a lot of things. These people, this set of people, they have a lot to offer us. They have something good to do. They have the resources, they have the technical know-how, they have the technology, they have the skills. So we need to collaborate with them to use all their resources to work for us. There was something that Private Sector Health Association of Nigeria is doing now. They call it Adopt a Facility. In each local government, they're adopting one facility where they would equip the facility and make it ready for use. So, and because they formed that association, they were able to aggregate their resources. It's not fragmented. They're able to make a difference. Now they are going to be doing that in 774 facilities across Nigeria. It's not sufficient, but at least it will go a long way. So private sector should also be considered when we are talking about collaboration in the health sector. So I think I'll stop here.
Thank you.
Okay, thank you very much. I think there's one thing that is very, very important. The parliamentarians are very, very important. We are looking for collaboration. We're looking for a team. When we talk about financing, there was a time, just a few months ago, money for immunization did not come out. We needed people to call stakeholders together. I knew that if my organization calls those stakeholders, they will not answer me. But guess who I called? The senator in charge of health. And then he made that call, and everybody showed up. And before we knew it, as we speak, that funding has come out. So when we talk about multi-stakeholder collaboration, don't take it lightly. Make sure that all these relevant stakeholders are available, are in that team, from parliamentarians to private sector. CSOs are the ones that can talk without fear. CSOs are so key. Then the citizens are also very, very important. Nothing for me without me. So they have to be in that particular group. So it's very important that we don't forget multi-stakeholder collaboration, and also the citizens. We are all very, very important. And I believe in Adopt a PHC. Do something different. The media, they are the only ones that can amplify and go very far. The media must be on the table. Adopt a PHC. There's something we're doing called micro adopt a PHC. You and I can take one PHC to adopt and just monitor the work that the government is doing. I've taken one to adopt. Today is Damangaza PHC. I go there once a month to see. You are supposed to have this. You people don't have this. You people that. Let all of us here, each person. The government is doing a lot. A lot of money is coming in. We have BHCPF. We have SWAP. We have so many things happening at the same time in this country. We all need to know about these things. And then we all need to take one PHC and adopt. Please don't take the one in your village. You are in Abuja. Take one that is near you so that you can monitor. You will be surprised what will happen. There's one woman, Bill Back, who adopted. We went to meet her. It's called micro adoption. Not people called micro adoption. Not people with too much money. She adopted a PHC. Today, that PHC, ANC in that PHC was 50 before. Today, 150. What did she do? She repaired one or two toilets. She cleared the debris that was there. She has adopted that PHC and she monitors it. Of course, in alignment with government. Let's all do the needful. Come out. Let's take charge. It's our country. It's our own. Let's do the needful. Thank you.
All right. Thank you so much. So I've been told that we are totally out of time. So unfortunately, we'll have to end this session here. I'm sorry, I really wanted to hear from the audience, but that's also part of why we're here. We're here to network. So if you have any questions for me or for any of my panelists, please just engage us during the networking break. Thank you so much.
Sorry, just before you close, I need to, just want to say this. For example, the World Bank the board of the World Bank approved a $570 million project for the health sector on the 26th of September. I'm not sure who in the room is aware and who's asking questions. What's the money meant to do? So we could talk a lot about the problems, but there are also emerging solutions. And I would like a situation where people ask questions. The monies will be provided by government. A lot of it has begun to flow to government. What are the terms of that financing? What's it meant to do? So just to put that on the table, that's a part of the conversation we also need to speak about sometime. Thank you.
Yes, certainly. Asking questions, demanding transparency, demanding accountability, and also using our voice to ensure that we're driving equitable solutions, to ensure that Nigerians and Africans at large have access to healthcare, have access to infrastructure that works. I think that we also need to be very, very particular about making sure that these systems work in our communities. So thank you so much. My name is Shirley Ewang, and it was a pleasure. Thank you all.
Let's just put our hands together for them. I'm sure you'll agree with me that this is such a brilliant way to kickstart. No, you can't go just yet. We have to take pictures. Forgive me. This is such a brilliant way to kickstart day 2 of the Media and Development Conference. So we'll just quickly take pictures. On the brighter side, I think a lot of us now know a little bit about reading MRI scans. You agree with me? But then there's a stark reality, 40% stunted growth. I think if that doesn't concern anyone, then there's a challenge. And that should arm us as journalists, media practitioners, to ask those questions. So once again, please, let's put our hands together for our plenary speakers and the moderator. Thank you for doing a yeoman's job. Once again, I'd like to welcome us all to day 2 of the Media and Development Conference, brought to you by the Center for Journalism, Innovation and Development, CJID. Coincides with 10 years of CJID. And I recall it was Dr. Kolishatima saying CJID may be an adolescent, a 10-year-old adolescent, but CJID is doing what 50-year-olds are doing. So if you don't mind, I'd like us to just give CJID a warm round of applause. Thank you for the great work you're doing, impacting journalists, thousands of journalists across the continent. My name is Kayode Okikiolu, gentleman of the press, anchor at Africa's News Leader Channels Television, and you may have met my colleague earlier on, Uju. She's done an amazing job, but I'll be taking over from here. So we'll move quickly to the next plenary for today, and guess what? It also concerns health. We're big on health today, and this plenary session 2 will be on improving women's health outcomes, addressing maternal and reproductive health challenges. It gives me great pleasure to welcome the moderator for this plenary. So please, let's give a warm welcome to Moji Makonjola, MFR, Managing Director of the International Society of Media in Public Health. Let's put our hands together for her as she comes on stage. Oh, she needs a hand. Careful.
All right.
We got you.
Oh, thank you.
Thank you. Thank you very much. And now to the speakers on this plenary. First, I'd like to welcome founder and CEO of Doctors Hub Nigeria, Damien Avar. Let's put our hands together for Damien Avar as he steps on stage. Also on this panel, we'll be having Dale Ogumbayo, Lead Healthcare Advocacy Initiative. Let's put our hands together for him. And joining us virtually is Professor Akoni Akinyemi, DVC Research, Innovation and Development of Bafemi Awolowo University, Ile-Ife. He'll be joining us virtually. Let's put our hands together for him. And last but not least, Country Director, Maris Stopes Nigeria, Emmanuel Aja. Let's put our hands together for Mr. Emmanuel Aja as he steps up as well. So we have about 40 minutes plus for this plenary, and I want us to please engage and really enjoy the conversation. So it's over to you, ma'am.
Thank you so very much. Good morning, ladies and gentlemen. I'm very excited that it's the men that's going to be talking about women's health. Since we don't have a voice as such in governance and how it happens, we hope that the men who are very committed, the he for she's here, will push us from where we are, the doldrum that we are, and to the reality of good things to happen. Thank you so very much. This room is very dark. Are you not aware that we have started the 16 days of activism, gender-based, to fight, to eliminate gender-based violence? Are we aware? Okay, so please orange the world. Moving on quickly. The statistics are there. I don't want to waste our time with that. We know what is happening. As we speak, I'm sure that 10 to hundreds of women would have lost their lives to bringing forth life, or we would have children that would have died as a result of not being able to access health, or the infrastructure is not right for women and children. Haven't reported health for more than 3 decades. I see it happening every day, and it should not continue. And I liked what Dr. Lumide said at the last, just at the last panel. Thank you very much. He alluded to the fact that there are supposedly some solutions in the air. How realistic are these solutions to meet our needs, our peculiar needs that will improve the health needs of Nigerian or indeed African women? So I would want us to drive not so much in terms of the problems that we know exist, but let's start looking at some of these new interventions and how we can make them work for the Nigerian women. So I hope our panelists that we are having virtually is here with us, right? But let me start with Lead Health Advocacy Initiative. Darling? Yes, I want to start with you. You and I have crossed our paths severally. And I know that it's not just about speaking to just about advocacy. It's speaking about the reality on ground. First, quickly, I'll give each of you a minute. Describe to us the state of maternal and child health today in Nigeria. Quickly.
Thank you very much. Good morning, everyone. Can you hear me?
Yes. Because of time, let's go ahead.
All right. Good morning, everyone. Well, it's painful and pathetic each time we have to discuss issues around maternal health in Nigeria. It's more painful because it has been on for so long, and we've had so many different types of interventions. We have made some progress, I must say, but we can do much better. And painfully, some of us are also getting older, and some of the things you hoped you would have seen at this stage in one's life, one is not seeing them yet with respect to maternal health care and the systems that we have put in place. So it's not been a good enough story. Again, we made some progress, but it's not good enough. And from Healthcare Advocacy Initiative, just like the moderator has said earlier, we've crossed paths so many times saying this kind of stuff. I'm a medical doctor,
painfully, or sorry, incidentally, now I'm a lawyer, and maybe now I'm seeing things from another perspective. We need to begin to compel these things to work. These interventions will keep coming. We have our health systems in place. Well, we need to also begin to find ways to compel these interventions to work so that tomorrow we're not back saying the same thing and then a new intervention comes up again.
Yes, I'll come straight to you.
Okay, thank you very much for that question. Personally, I think, just to add to what my co-panelist here said, we have made some progress, quite all right, but there is still a lot more that we can do. Now, if you consider the statistics, Nigeria still has one of the worst maternal mortality rates in the world. And, despite the efforts being made, we have still fallen short of meeting the WHO's recommended value of about 70 rather. All right, so we still have a lot of work to do, particularly now that the health system is a little bit distressed. There is a massive brain drain. It's affecting the quality of care. It's affecting access to care. So I think it's high time we had this discussion and provide solutions.
Thank you very much. Yes, I'll go straight to you. Can you use your mic? Yes, okay. Aristos. Yeah. Same question. All right.
Thank you very much, Moji, and thanks, audience that are listening to us. I mean, just joining my other colleagues here, we have made some significant progress as far as maternal and child health is concerned. If I look at where we are coming from, just looking at the data that were presented 3 weeks ago at the SWAP meeting, talking about the movement in MCPR, which is one of the things that we want to see. We have seen some significant progress in some states, and then at the national, though that is not where we want to be, but those level of progress that we are seeing and the level of effort that is coming from different partners gives us some hope that collaboratively, if we continue to come together as partners, we will definitely move the needles.
Thank you very much. Is Professor Akoni Akemi, can you hear us, sir? I would also like to have your views before. Yes, thank you. Your own. I think there's a problem with his audio.
Can you hear me?
Yes, we can.
Oh, good morning. Thank you again, Auntie Moji. Nice again meeting you, though virtually now. And again, let me apologize. I have a lot of commitment in the university to join. Just again to add to what the other speakers have mentioned, that maternal and child death in Nigeria is still at very worrisome levels. If you look at the national statistics, we are talking about more than 500 maternal deaths within 100,000 women who are pregnant in a year. That is heavy when you compare what that translates in terms of the numbers. As also mentioned, for infant and child mortality, the situation is not looking good. Let me put in a very layman language to say that among 13 children who are born in one day, we will lose one before age 1. And also before they reach age, their 5th birthday, we are likely to be talking in terms of losing 1 out of 8, which is not a very palatable thing. But that's at the national level. So when you look into it at sub-national level, it's more worrisome in some geographies compared to other geography. But I think as we continue this conversation, I'll be able to shed more light on that. Yes, it has been very static within these last 5 years for infant and child mortality rates. But for maternal mortality, maybe we have some little success, but it's not something to really celebrate. Just a little success that we've had. Thank you.
Thank you so very much. So we have a foundation we have a background and we understand that the situation is such that we should wake up from our slumber, make whatever interventions that have been alluded to or brought in, make them work. I think our discussion should start looking at to making them work. I said, I'm tired of the problems. They're there. We speak about them every day. Let's be innovative. Let's start speaking to which way forward. And we have SWAP now, which is a wide sector approach to getting things done. We have a new one that has just been birthed. It's called MAMI, that is going to disaggregate those who are doing well and those who are not doing well, and so that we can benchmark on the things that are working and make them more sustainable. So let's start from the very beginning. We know what is wrong. Going forward, what are we supposed to be doing? I'm going to start with you, Emmanuel. Yes, Dr. Damien, sorry, Dr. Damien Ava. Okay, what strategies have you implemented through Doctors Hub that you think can push us from where we are now? Because there's no time. Somebody, I'm sure a woman would just have died. Very distressing. But this is avoidable. These are avoidable deaths. So let's hear from you.
Okay, thank you for that question. So I should just briefly share my story with Doctors Hope. So sometime in 2016, myself and a group of other doctors decided to set up Doctors Hope. And the goal essentially was to try to ameliorate the very dismal doctor-patient ratio. As at then, it was 1 to 5,000.
It's worse now.
Now I think it's about 1 to 9,000 thereabouts. So you can understand that we have a big challenge on our hands. So the goal essentially was to leverage digital technology to try to address the inefficiencies in the value chain. One of the panelists earlier was talking about somebody leaving the PHC, going all the way to a tertiary center. You know, I've seen cases of a woman. I had a particular one because I had to deal with that. The woman left Ogun State. Can you imagine? She left Ogun State with a baby who was convulsing and traveled all the way to Lagos Island. Massey Street convulsion seizures had already set in. So there was a need for us to try to address some of those inefficiencies. So we started the platform, and it's a digital health platform, essentially telemedicine, to provide an alternative for people like that, or for people who might need such platforms to be able to reach a doctor at any point in time. Now, there are three delays when it comes to the issue of maternal mortality in Nigeria. The first delay is the delay that happens with the patient. The patient fails to seek help at the earliest stage possible, right? So the patient is probably the pregnant woman is having pains or abdominal pains, but because she's not well informed, she's unable to know the right time to seek for help. That's one of the delays. The other delay happens when you consider the environmental context, maybe bad roads, no vehicle to transport her to the hospital. And then there is also the delay that happens at the hospital, maybe bureaucratic delays, administrative delays. Our target essentially was to address the first one, the delay that happens with the initial.
So how far did you go with this?
So during our first year of operation, we were able to, process close to 10,000 doctor-patient relationships that included inquiries, second medical opinions, consultations, and online referrals. Now that's interesting because sometimes these people don't even know the exact or specific place to go. That's us collaborating with hospitals, pharmacy outlets, labs.
And this has worked.
It has worked. In fact, I should add this. We eventually narrowed it down to addressing pregnancy-related issues. And over the last 2 years, we have seen about 3,000 women, pregnant women, pass through our program with zero mortality.
Wow.
Zero.
Wow. Good news.
Zero mortality.
So we need to push this out. We need to give visibility to what is working. And the project is still on?
Yes.
Absolutely. Okay. So we need to track it. And that's where visibility, and thank God for CJID, this is why visibility is important, that we're able to track what is happening, what is working, and so that we can benchmark on it and spread it. Okay, I'm coming now to Dale Ogunbayo. You lead a health advocacy initiative. You spoke at the very beginning. What is it that can carry us through this new innovation, like what he has alluded to, so that it's not just about government now. We're looking at private sector intervention, particularly in, closing the gaps that he has mentioned, human resources, access to healthcare, getting to know what are the danger signs. How do we put all this together in our bid to reduce maternal mortality?
Well, from our position, as healthcare advocacy initiative, one of the things we are seriously focusing on is patients' rights. Many things have been done as forms of supply to the people, but we want to push things to a point where the people are the ones demanding. It's great what they have done. I mean, thank God, being a doctor, he could create these things, but we need to get things to a point where the people that we're to serve are demanding some of these things. One, two, one of the most moving things that happened to me as a young medical student in the 80s was that we're showing a film titled "Why Did Mrs. X Die?" And at the end of the day, a lot of things were highlighted. However, for me, what that means is we must get as citizens to a point where the life of a woman is not reduced to numbers. That one, two people have died. No. Why did this woman die? We should have, what we are trying to do now is collaborate with a few more NGOs who may be interested in forming a network where when a woman dies at childbirth, we go through it, we drill through it. What happened? With the aim that possibly somebody may have to be punished, or this family would get some civil redress. We can't keep teaching lives of people as if it's just mere numbers. And as much as we think policymakers aren't bothered, the fact is, when somebody feels, a policymaker, a governor, whatever, feels threatened because some nurse, some health worker mistreated a woman and she died, he's going to take action. But the way we treat it now, we just say, oh, that hospital didn't do well. No. Who didn't do well in that hospital? Who was supposed to be in charge? Now, when you deal with people in power, they work based on either of two P's. It's either pressure or pleasure. We as citizens need to put them under pressure. That is, you don't let the molehill become a mountain. One death in one community, there's no rest. We're questioning, we're asking, we're writing questions. So everybody will know that we can't afford to have another death. Now, when it gets to a point where a politician knows that if he solves...
Take that hot from you and run it to Prof. Prof, are you on? This is what we'll see.
Yes, I'm on.
Yes,
yes.
we do not have people's engagement in healthcare. We have refused to recognize that healthcare, particularly as it concerns the women and the children, it's a developmental issue until we start taking that on. So, Prof, what are the new discoveries from the global research community that could help to improve maternal health care in West Africa, IDSC, Nigeria, and how can we effectively translate these research findings to reality?
Thank you so much, Ma. First, let me say what evidence show. So what are we really talking about when we talk about maternal mortality or maternal deaths, particularly in Sub-Saharan Africa, West Africa, and particularly in Nigeria? These things, evidence have shown what it means and where it is concentrated. First is about a woman developing complications during pregnancy, which can happen to any woman. Either you're educated, you are not educated, you are young, you are old. But pregnancy complications can happen to any woman. The second one that is a major cause of maternal death in Nigeria and many West Africa countries is unsafe abortion. People who are pregnant when it's unplanned for, and that resort to all kinds of approaches just to get rid of that pregnancy. That's the second major cause of maternal deaths that we have in Nigeria and many West African countries. The third one is what we call high-risk pregnancy. When you are too young to be pregnant, or when you have too many children. I mean, within